Hello, everyone. Thank you for attending today's webinar, Virtual Health, Driving the Future of Virtual Care Delivery Models, presented by Deloitte. I'm Andrea, and I'll be moderating this webinar. Our speakers today are Ann Phelps, Principal, Regulatory and Compliance, Deloitte, Bill Farah, Principal, Strategy and Analytics, Deloitte, Sean Rangappa, Managing Director, Organization Transformation, Deloitte, Urvi Shah, Senior Manager, Customer and Digital Transformation, Deloitte, and Ken Abrams, Managing Director and Chief Medical Officer, Strategy and Analytics, Deloitte. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. If you'd like to download resources to supplement the presentation, please click the Handouts tab button on the left side of your screen. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your volume is up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. All right, we are going to begin now. Ken, please go ahead.
Thank you very much, Andrea, and welcome everybody to this afternoon or this morning, depending upon where you're located, presentation on virtual health. On behalf of Deloitte, we are thrilled to be able to participate in this webinar and share the thoughts and experiences and knowledge that we have around virtual health, and as we're seeing it evolve in the greater ecosystem and healthcare changes that we're all living through today. Let me start by asking some of my colleagues to go ahead and introduce themselves. We'll go ahead and do that, and then I'll run through the agenda, and then we will go ahead and get started pretty quickly. So Ann, let me start with you.
Great. Thank you, Ken, and thanks for including me today. I'm happy to be here. Hi, everyone. This is Ann Phelps, and I serve as our U.S. Healthcare Policy and Regulatory Leader at Deloitte, and I'm based in Washington, D.C. Thanks, Ken.
Thanks very much, Ann, and it's always great when you can join us for these discussions because of everything that is going on in and around Washington, and particularly as it relates to healthcare. So thanks for being here today. Bill, how about I hand off to you?
Thanks, Ken. Good afternoon, everybody. Pleasure to be here. My name is Bill Farah. I'm a family practice physician by background and training, and started my career in industry and family practice at University of Pittsburgh Medical Center. In 2008, I helped to launch the first enterprise strategy in virtual health for UPMC, as well as launching an entity called the Center for Connected Medicine. For the last 10 years, I've been in professional services and currently lead the virtual health practice at Deloitte.
Great, thanks very much, Bill, and we really look forward to the insights and experiences that you'll be able to share, both from our perspective as a firm, but also, the evolution that you've seen over the years. So, Urvi, pass the talking stick off to you.
Thank you, Ken. Hi, everybody. Good afternoon or good morning. My name is Urvi Shah. I'm a senior manager at Deloitte. I help Bill and Ken lead our virtual health practice. And I really focus on the intersection of the human or customer experience and virtual health. So really thinking about how these digital tools and technology capabilities that we are utilizing can really help engage individuals in their health and well-being in a different way. So really excited to be here this afternoon.
Great, thank you, Urvi. Really appreciate that. And you didn't mention the expertise you bring to this work as being an engineer as well, a biomedical engineer for that matter, which has been invaluable to our development and evolution of virtual health. So thank you for all you do in addition to being here today. Sean?
Thanks, Ken. Hi, everyone. I'm Sean Rangappa. I'm an internal medicine cardiovascular physician. I'm in the Washington, D.C. area and have been part of the life sciences and healthcare practice at Deloitte for 16 years. I help engage physicians, clinicians, and other stakeholders in changes to their work that are enabled by technology. I've been involved in virtual health along with Ken, Bill, Urvi, and Ann, and specifically help lead our telecritical care efforts within virtual health across both commercial and federal environments. It's a real pleasure to be with you here today.
Fantastic. Thanks, Sean. And there's a lot going on in and around the telecritical care environment, which we look forward to hearing about and having a discussion together around. So thanks again to my colleagues for joining us today. Good day, everybody. My name is Ken Abrams. As Andrea mentioned during the introduction, I'm a managing director in the firm. I do serve as the firm's chief medical officer, and I'm privileged to be able to serve in that role, particularly during the time of this public health emergency and pandemic that we've been living in. Like Sean and Bill, I too am a physician. I'm an anesthesia critical care physician with 25 years of experience on the healthcare industry side, both practicing clinical medicine as well as serving in a number of senior executive roles. And then I've been with the firm not 9.5 years now, and have had the opportunity to work with this great team and many others as we've continued to evolve our contributions to the improvement of healthcare around the country. Today's discussion, we're going to focus on virtual health, as we talked about, and this is a great group of people to get together with. Here's what the agenda looks like. You can see in front of you on the screen. We're going to start off with really setting the stage around what's going on from a regulatory and governmental perspective. I can't think of anyone better than Anne to share that with us. And then I will spend a few minutes talking about the journey of virtual health as we see it as a firm, and how it may fit into the broader ecosystem of improving the ability to care for people and improve health and well-being. And then Sean's going to take us on a bit of a dive into what's going on around critical care. There's a lot happening around the country, and our involvement in that is extremely important and valuable to us. So we look forward to that discussion. And then following Sean, Irvi's going to talk with us about how we're bringing acute care capabilities into people's homes. It's a little bit perhaps of going back to Marcus Welby, but maybe Marcus Welby in the 21st century. But our ability to do that in today's day and age is pretty remarkable. And then Bill will round out the formal part of the presentation materials, talking about how do we manage disease on a more continual basis, and the capabilities that exist for us to be able to accomplish that today as well. From there, I'm going to move into a roundtable discussion, and I will ask the team members on this call today, a couple of different questions to kind of get us started, and hopefully that will get all of you started as well, and encourage you to add your questions into the Q&A box on the webinar, and we'd love to capture as many of them as we possibly can. So if there's a lot of questions there, I may not even need to use any of mine to go ahead and get the group started. So with that, it is my pleasure to hand the microphone over to Anne and allow her to take us through a bit of a tour of what's taking place in and around regulation and in Washington. So Anne, over to you.
Okay, that's great. Thank you, Ken. So everyone, today I thought, I would kind of lead us through three different topics. I've been in Washington. This is my 32nd year, so I've lived through a couple transitions, to say the least. And so I thought, first of all, I would just kind of start with a quick summary of kind of where we stand today with the new Biden administration. It's been a really busy, January, and I thought I would start with a little bit of just kind of what are the overall priorities of the new administration to set the stage. Then, to also help put things in context, talk about a few minutes on the healthcare policies I see that will probably be in focus in 2021, both on the legislative side and also on the regulatory side, because I think that's equally important as we plan for what healthcare is going to look like and what's going to change or stay the same in Washington. And then finally, I will focus in on what is happening in part as a result of COVID, what is happening in consumer-focused care and virtual care, and the regulatory factors in play here, some things that have changed, that, what's temporary and what might become permanent in our healthcare system. So those are my 3 topics for today. I'll keep an eye on the chat, so please do, ask questions of us. We would love that as we move through today's dialogue. Okay, so I think many of you have seen as President Biden was sworn in on January 20th, throughout his campaign and as he has moved into office here in Washington, there are 4 main policy priorities that he and his new administration have articulated in the past couple of weeks. And we're seeing this in a variety of ways. The most significant thing we've seen are the issuance of executive orders. So there have been a number of executive orders that have come out. You can find them on the White House webpage. And importantly, the one thing I do want to emphasize as a regulatory leader is these executive orders really help provide us with where the administration wants to go. It's like a directional compass. Executive orders, they don't carry the weight of law, but they generally say, here's what I want my administration, the federal agencies, Congress to focus on in the early days of an administration. So these are the areas you see on the slide here in which the administration has been focusing the past couple of weeks. I always kind of say first, second, and third is the response to the pandemic and COVID-19. The administration has put out a couple of different documents, one of which is a document that instructs the federal agencies, each agency across healthcare and beyond, activities or policies that he would like to see them undertake that are within their own authorities. And a lot of that has been around the vaccine distribution. President Biden also put out a document which was about sort of the recovery plan and response plan that was more directed at Congress. You might have seen this in the news. This is the sort of the $1.9 trillion package of legislative proposals that he would like to work with Congress on in a bipartisan way in the coming weeks to pass additional legislation and funding for response to COVID. Now, that's going to take an effort by Congress, either in a bipartisan way or potentially they can use different vehicles where they might pass it on party lines. But we'll be watching that carefully in the next couple of weeks. There have also been, and we expect, further executive orders with respect to economic recovery, further legislative proposals, climate change, and racial equality. So these are the sort of priority issues that the government is focusing on in the new administration in the early couple of weeks. Now, as I move to the next slide, let me talk for a minute about the healthcare agenda and to sort of put in context where I think we are. And you're going to probably see my bias when I say, not just because I'm a regulatory leader, but I do still think a lot of the action in this first year is going to be through the federal agencies. So in addition, though, to COVID-19 response, President Biden has a series of proposals to expand coverage, whether that is through Medicare expansion, a public option for insurance coverage, and expansion and shoring up of the Affordable Care Act. In addition, I call it a little bit of a strange bedfellows issue. There are a number of proposals that he has, as well as the agencies and the Hill, where they're examining reducing the cost of care through prescription drug prices. Now, I will say, I think in part because of the competing priorities, the realities of the budget, and the fact that the Congress right now is pretty closely, divided. The Democrats have control of the House and Senate, but they're slim majorities. So a lot of negotiation is going to have to occur. So with all of those factors, slim majority, competing budget priorities, the restrictions of the calendar, I really think in some of these healthcare areas, we're going to see what I'm going to call some smaller changes. I really think the expansion of and sort of the shoring up of the ACA will be first on the agenda, particularly in light of COVID. I think other issues such as Medicaid expansion and public option are not likely to occur right away and are going to take more time. I don't really see those things happening in the early part of this year. I think most of the focus is going to stay on COVID and shoring up the ACA to ensure that individuals have coverage, particularly during this time of the pandemic. Now, it won't surprise you that I think a lot of the activity, as I move to the next slide here, will remain on the regulatory front. And I wanted to highlight, I'm happy to answer a number of questions. I think there's a lot of activity around coverage, as well as value-based care payment models, innovative payment models, and certainly virtual health that are going to continue in the Biden administration. I also want to say that many of these proposals that I'm going to discuss today have bipartisan support, so I think they will continue. So I'm going to hover, Ken, for a couple minutes on this slide because I think this is probably of most interest today to our audience. So we've all seen, and my partners today are going to talk about how virtual care and telehealth has grown extraordinarily during, in the past, of course, the past couple of years, but in particular due to the public health emergency and the crisis that we're facing, because we had to respond quickly and figure out other ways to deliver healthcare fast and efficiently and keep people safe. So first and foremost, I do want to say that I believe that some of those flexibilities under the public health emergency will continue. I also think the public health emergency will likely continue throughout 2021, at least until the fall. And what that means is that some flexibilities in terms of expanded reimbursement, relaxation of some rules will continue to occur. So the public health emergency, unfortunately, we're not out of the woods yet, and I think will continue. So as you can see on the slide, there's been a number of flexibilities that have been given that have responded to the emergency that I do believe will continue. And I really, Ken, as you and I were talking, I really want to hone in on two in particular, and that one that I don't think has been talked about as much. So the two I want to hone in on are the telehealth rules and the hospitals without walls. So the expansion of telehealth under the previous administration, and I do believe will continue under the Biden administration, is likely to continue. CMS put out some new expanded flexibilities in December 1st of 2020, when they issued the annual physician fee schedule. And as a result of the public health emergency, they have greatly expanded a number of services for telehealth that can be reimbursed through Medicare. I think we're up to almost 150 new or expanded telehealth services. This is everything from receiving it in the ER to virtual care centers to at home. There's a variety of different codes as well as settings that these telehealth services can be provided. CMS, I looked at their recent numbers, has estimated that 25 million of 63 million beneficiaries under Medicare have received some kind of telehealth service during the pandemic, greatly expanded. Now, one thing I will say is these are still, extended and expanded services. They are not yet fully permanent. The administration is very likely, as Congress will continue to evaluate data and collect data on the efficiency and the quality of telehealth services. One of the things we as a team have always talked about is, like any other expansion of a Medicare benefit, we will continue to have to be vigilant to prove that we are efficient users and high quality users of these telehealth services in order for them to become permanent. Okay, the next subject I'll raise here is the hospitals without walls, or what is otherwise sometimes known as the acute hospital care at home. Now, these were rules and flexibilities that were initially put out in March, but it was at the end of March where Hospitals Without Walls, the program, was established. And then CMS released additional guidance at the end of November in 2020. And in essence, what they have allowed us to look at is nearly 60 different acute care conditions, things like asthma, COPD, pneumonia, other types of acute care conditions where, with the appropriate safeguards, patients can receive care within their home with appropriate clinical care, safeguards, and through remote patient monitoring. Flexibility has also been given to ASCs, ambulatory surgery centers, to allow for patients to stay in those centers for longer than the usual 24-hour period of time. Again, these are temporary flexibilities that I suspect might become permanent depending on what the data shows. And Ken, I looked this week just to see what our latest numbers were. And at the end of the Trump administration, so as of 1/19/21, so just about a week ago, there were now 38 healthcare systems, 92 hospitals across 24 states participating in the Hospital Without Walls program. So I found that to be amazing, an amazing statistic of what we've seen in the growth in the past couple of weeks and months. The final comment I'm going to make, and then I'll pause and turn it back to you, Ken, is this is a little bit of something that I like to talk about. It doesn't always come up as often, but there are new rules for plans and providers in the healthcare space around interoperability and being interoperable. And many folks will ask me, okay, and well, what does that really mean, and why are these new rules different? And one, I'm going to say they are final rules for plans and providers that go into effect this year. And what's really disruptive about them is it's requiring coordinated care and a way of communicating that is different than we might have done it in the past. It really follows the patient and wherever the patient goes, and requires plans and providers to discuss and communicate with each other, even if they are not in a contracted network. It follows the patient. Wherever that patient goes, communication must follow. So I really think it is going to, and many people have said if we'd had some of this at the beginning of COVID, we might have been able to respond quicker. So I think interoperability is an important issue to add to our suite of things that we look at in terms of the communication and use of technology. So Ken, I'm going to stop there and pause. I'll take a breath and let you or the team react or take any questions.
Fantastic, Anne. Thank you very much for that overview. I know we can spend an enormous amount of time digging into the regulatory both challenges and opportunities that exist out there, but it is amazing to see the uptake, especially as you described with respect to the Hospital Without Walls program, Acute Hospital Care at Home program, whichever phrase we want to use for it. The uptake has been pretty significant, and we've seen that play out in the marketplace with our clients as well, as I know Irvi's going to talk about in just a little bit. So, Anne, not seeing any questions just yet coming through on the Q&A. We will get into some of those during our discussion in just a little while. But for now, let me go ahead and take the microphone from you and move on a little bit to the overall vision for what we see around the ability to deliver virtual care over the course of a patient's longitudinal journey around care. So this is obviously a bit of a busy slide, so I want to just unpack a couple of points here. When we think about the role and the opportunity for virtual health in today's environment, what we're really looking at is how do we take advantage of technological capabilities to bring the highest degree of professional care to patients wherever they may need it over a continuous and continual basis. So it's really about what I'll call the longitudinal care, where we can move from environment to environment, ensuring the continuity of care, and as Anne said, through interoperability, ensuring that the information necessary to provide care continues to follow the patient along the way. So we're going to take a deeper dive into some of these in just a moment. We're going to take a deep dive into the eICU concept or tele-ICU concept, and how does that provide care to individuals within a given hospital and then move it through, but also how do we provide that care to more remote locations and perhaps more challenging environments. And I know Sean's going to touch upon that with some of our experiences. Within the Acute Hospital Care at Home program, right, the ability to not only deliver true acute care hospital services in people's homes for conditions like pneumonia, vasculitis, or others, but even exacerbation of heart failure, as you see here on this slide, right? If you walk through the actual patient journey, from the time that they get discharged early to that ongoing continuous care. And Bill's going to talk about how do we continue that connected care in an environment with somebody like a patient with a heart failure condition, to ensure day-to-day continuity and connectivity, the use of technology as a means of communication, and then supplemented, of course, with other communication capabilities like video conferencing and the like, but using device monitors and wearables to ensure that we've got connectivity of patient data on an ongoing basis. And then, as I mentioned, Irvi's going to take us on a journey through a hospital in-home and what that looks like, and how we've really been able to evolve to the point of bringing hospital-level care into patients' homes when it's appropriate for them and the environment is appropriate to do so. So with that, let's go ahead and get started on some of this deeper dive into some of these more appropriate and defined areas. So Sean, I'm going to hand it off to you and ask you to start sharing your thoughts around critical care and what we're seeing with respect to virtual health.
Happy to do so, Ken. Thanks for the opportunity. As Ken described, the care of patients is indeed evolving rapidly across the continuum of care, and no matter what environment we're considering. Patient journeys like the heart failure example Ken cited can take multiple paths, and Anne shared the obvious reality that COVID-19 has been influencing and stressing almost all aspects of our healthcare system. What's shown here on the slide being projected is a representation of a core idea that even patients labeled as with a chronic condition, or those that are billed as needing intensive care in our COVID emergency currently, still need, one, appropriate triage, intake, and diagnosis, and then two, provision of the care in question, and then three, a good deal of disposition or detailed planning to ensure a focus on continued wellness and not just treating the one episode in question that brought the patient in. We've seen significant and rapid evolution in our ability to deliver critical care essentially without walls via virtual health technologies and processes. And the COVID-19 pandemic obviously has illuminated our critical care delivery challenges and has fostered some fascinating innovations that we've been seeing across the industry. And I'd like to just share or summarize a little bit of what we're observing by first reviewing a bit about the challenges that COVID-19 has presented. Obviously, those challenges include limited facilities that can extend the high acuity critical care. There's also the lack of or very nascent virtual health capabilities in some organizations, lack of self-contained secure IT systems, and sometimes limited clinical collaboration tools that can help extend critical care clinician expertise remotely and rapidly to support both traditional and non-traditional facilities. Traditional tele-ICU programs have focused a lot on the surveillance and care of ICU patients in one facility or one organization, or perhaps across multiple facilities in a large multi-site organization. But we, as a collective system or society, haven't really created low-cost, cloud-based, secure, standalone systems that use non-proprietary standards to help deliver critical care and provide caregivers with information that they need. This is something that's become a priority and has been driven a lot by the COVID-19 emergency. One example that Deloitte's been heavily involved with the Army, the Department of Defense, and now Health and Human Services, has been in supporting the creation of what's called the National Emergency Telecritical Care Network. And this is an innovative way of thinking about telecritical care in that it's designed to address this problem of needing to bring care anywhere, because we've all been remembering the challenges in the spring of last year and the ongoing challenges related to ICU capacities around the country in various pockets, but we've all been experiencing them in our markets. And so the idea of bringing high quality emergency and critical care support to any bedside at any time, whether it's in a field hospital, whether it's in the facility that you're administering, or whether it's in a gymnasium that needs to stand up to provide acute or critical or COVID care, all of those require processes, people, technology, steps that we haven't really seen brought together in a concerted and organized and effective way. But now we're starting to see some of that play out with this National Emergency Telecritical Care Network. fundamentally, it's a network that's designed to be easy to use, readily available, and allows, via the concept of what's called a virtual ward, to deliver care using clinical care teams that are composed of clinicians in an organization, but supported or supplemented by volunteer clinicians, the defense, federal clinicians, as well as retired clinicians. And these are organized in a way that helps to quickly answer questions and manage critically ill patients via telementoring, which we're seeing increasingly be a critical part of the tele-ICU care provision. It also allows for reduction in local caregiver task saturation, giving local experts downtime, basically, and then broaches into the area of remote home monitoring for patients to transition into going home or at least getting to the next episode of care more quickly. So in general, I'd love to share a bit more detail about some of what we're seeing evolve related to what this NETCN, or the NETCCN, the National Emergency Telecritical Care Network, promises to provide as a model for a lot of healthcare systems. So Ken, let me stop there in terms of just describing the fact that critical care provision across the continuum of care, we believe, is a trend here to stay, and maybe get into some of the deeper discussion during our Q&A and during our internal dialogue.
That's fabulous, Sean. Really appreciate that perspective and the value that it brings. I know we're getting some interest on the chats around reimbursement, whether it's been supportive or not, around virtual critical care. Maybe that's something we can pick up on in the discussion in just a little bit. For now, Irvi, let's turn over to you. We've talked a lot about hospital and home. I know I've talked about it in the introduction. Anne's talked about it. It's come up time and time again. We're seeing lots of it in the marketplace. Share some of your perspectives and learnings, please.
Absolutely. Thanks, Ken, and thanks, Sean. As we think about hospital and home, again, across the continuum, what we're seeing is a few entry points or several ways of thinking about how an individual might be, quote, admitted into hospital at home. So if you think about an ED diversion, so somebody coming to the ER and, potentially, getting admitted for, overnight reviewing, and then, thinking about pre-scheduled hospital stays. So the most common one that we're talking about and we're hearing about are post-op recovery stays. So, thinking about a joint replacement or a planned procedure that may enable an individual to not actually have to come into an inpatient admission, but rather be connected 24/7 with a care team while in the comfort of their own home and in the safety of their own home, which has become a more critical factor in thinking about risk of inpatient admissions, especially during our public health emergency. So those are a few of the ways that we're looking at hospital and home. And the third one is around reducing length of stay. So if somebody is having an acute event that requires observation for a longer period of time, that could potentially be done in home. Now having the technology to be continuously connected to a care team that's on call and even potentially monitoring you 24/7, but also having the ability to have the logistics around supply chain, potentially some home health type capabilities with physical check-ins available to an individual as needed and as quickly as needed, depending on the criticality of the incident, has been something that we've been working really hard to ensure we can actually think about that from an ecosystem perspective. So as we think about this individual journey and this individual's journey, ensuring that the individual has the appropriate environment and caregiver support in the home, but also really empowering that caregiver to to engage and be an active participant in the care and the patient's recovery is something that that hospital and home can really provide a significant amount of value to. We also think about, and again, I'm not going to unpack every step in the journey, but you can imagine, the different entry points that an individual can have, and then the continued engagement. And I'm going to move to the next, piece that I want to make sure that we cover is really this perspective of the ecosystem of capabilities that are required, and what we're seeing in the market today, and and your update on how many health systems and organizations are incorporating hospital without walls into their care models is pretty significant and powerful. Starting to really think about what that looks like from a sustainable perspective, and building upon the capabilities that an individual health system might have that that they may need to plug into or might be able to enable, like through home health, for example, or may need to partner with from a supply chain perspective or a command center capability that they can expand on. So the way that we think about hospital at home goes well beyond the technology that's required, or the requirement to completely outsource or insource all of the capabilities that are required, but really trying to pull on and draw from the functionality and the capabilities that a health system or a healthcare delivery network might have to offer to their patients, and then thinking about what are those capabilities that can help augment that. So a little bit about hospital and home, and I know there's a lot of questions that are coming in, so we can certainly continue this discussion during the Q&A or the discussion. But Ken, anything else that you want to make sure that I'm covering as we start talking about hospital and home?
No, I think that's a great start, Irvi. And as you said, we're starting to see questions coming in for sure. So we're going to have a lot to talk about in our discussion period. Maybe what we'll do at this point is hand it over to Bill, and let's take a look at how do we maintain a level of care for people once we've gotten through these acute periods, whether they're critical care or an acute hospitalization, regardless of whether it's in the home or in the four walls of the hospital. But Bill, maybe you can help us understand a little bit better as to how do we maintain that connectivity, and how do we ensure that people with chronic conditions can really stay connected as opposed to just intermittent episodes.
Sure, Ken. And I think that this field, this notion of remote patient monitoring really starts to recognize the full promise of longitudinal continuous care that you and Ann and Sean and Irvi have been talking about. And there's really the potential for full transformation in this area and transforming to truly patient-centered care models. Although these other elements are elevated models of care, I would say this notion of remote patient monitoring truly has a promise to transform the way we take care of patients and the way that patients and customers engage in their own care. And we're also seeing some good movement from a regulatory standpoint and reimbursement for chronic care codes. And I'll ask Ann to talk a little bit more about that as we get to the Q&A session. But there was also mention in our Q&A about innovation and new developments in the area of virtual care. And again, I think this area is ripe for innovation and disruption from a technology standpoint. And we're seeing that it's becoming easier and easier for patients to get biometric data from their home to a clinician or a care team or a health coach. Devices that have been non-invasive, such as rings and watches, are giving way to more and more wearables, where you only need a camera to be able to monitor vital signs and transmit data to care teams. A lot of the ethnographic research that we've done about chronic disease management programs and devices is that patients really want to personalize them. Every patient wants to have something slightly different in the way that they're cared for, the way they engage with their care team. And so the ability to have configurability of these devices and of these care environments is really going to drive patient engagement and true behavioral modifications. And I think, in addition, we're going to see more and more advanced analytics in this space from not only a predictive standpoint of knowing when somebody is about to get into trouble, but from a prescriptive standpoint and understanding what the next best action is to help that patient or for that patient to take to avoid trouble. So this combination of really easing the burden of transmitting information and biometric data, the advancement of configurability and personalization to help patients want to use these tools and to benefit from them more easily, and finally, the complementary, extremely advanced analytics that we're going to have both from the prescriptive and predictive nature really can allow a full, continuous, longitudinal care that engages not only the patient, but the patient's caregivers. So the other thing that we're able to do with these technologies is create and enhance outreach to spouses, to children that are caregivers, to parents that are caregivers, so that at any time, caregivers and care teams can be aware of what's happening with a patient and help them to avoid any complications or exacerbations of their chronic conditions. So again, with that, Ken, I'll pass it back to you, and I think happy to go into a Q&A session at this point.
Great, thanks, Bill. Really appreciate that. And since we're going to move into the Q&A, I'm actually going to start with you, if you don't mind, since you still have the talking stick in hand.
I have it.
How far do you think we're going to go with virtual health? Are we going to get to the point where hospitals are going to become obsolete and we're not going to need them anymore? Or, is there some other goal or destination that we're trying to strive for?
It's a great question, Kat. I don't think we're ever going to completely eliminate the need for acute care centers and hospitalizations, whether that's advanced procedures, whether that's transplants, whether that's joint replacements, abdominal surgeries, cardiovascular surgeries. Those will all still require acute elements of care. Trauma is another example where I see we're not ever going to completely get rid of hospitals, but I think that we will see hospitals become more true tertiary and quaternary care centers, that other sites of care will start to rise up, including the home, including ambulatory surgery centers, including infusion centers that are decompressing our hospitals so that only the sickest of the sick that need to be in those hospitals are. The rest of our population that can be taken care of in alternative sites of care, and quite frankly, in sites of care that they prefer, to be at home, to be surrounded by loved ones, to recover and recuperate in a more relaxing and familiar environment. So I don't think we'll ever get rid of hospitals, but we certainly will continue to advance the number and the acuity of situations and scenarios where we can take care of patients in alternate sites.
Yeah, which obviously has some great benefits, and I'll add on top of what you already listed, right? The opportunity to avoid hospital-acquired conditions.
Yes.
That we all know are dangerous, right? We've been there, and we know what that's like, and the impact that can have. So thanks, Bill. Let me move on to a question from the audience that we've gotten in, and I'm probably going to ask several of you to weigh in on this question if that's okay. But Anne, let's go ahead and start with you. A lot of interest around the specific fee-for-service coverage, coding, and reimbursement, and what that's going to look like, and as it evolves, value-based contracting payments for virtual healthcare solutions. So, a big question that I know each of you has a perspective on, but Anne, let's start with you.
Yeah, sure, Ken, and that is a big question, and it's not an easy answer. Excuse me. Sorry if I'm cough there for a second, apologize. It's not an easy answer, but let me try to break it down a little bit. So much of what I was discussing during my early part around specific reimbursement for telehealth and virtual health, a lot of that is reimbursement through the physician fee schedule. So it is something that, under Medicare, clinicians and physicians can be reimbursed for specific services, and that is still in what we'll call a traditional fee-for-service coverage and coding. However, and one of the reasons, and you can go to CMS's website and pull down the telehealth, the specific services for telehealth, or in the Hospital Without Walls program, the different acute conditions like that you're mentioning and talking about today, where you can receive direct reimbursement. I do want to make the point, though, and I think it's a really good point that our listener raised, which is as we move towards value-based care and coordinated care, the previous administration, I think the Biden administration, are going to continue to push for innovative value-based care models and coordinated care models where they look at the quality of care delivered, the efficient use of care, the ability, as I said, to be interoperable, and as Bill was so eloquently describing, to communicate with other providers. And you can do that in various virtual care models and other types of innovative models, and quite frankly, can receive even higher reimbursement. The move to value-based care is challenging, but it also allows for certain bonus payments and higher reimbursement. And so I think both models are really worth considering. And as you also said, I think as well, look, not everything is going to move out of the acute care hospital, but these do provide incentives to do this care in new ways and be reimbursed.
Yeah, and I think those are great points. And if you don't mind, Ken, I would just like to add on to something about what we're seeing in the market as it pertains to value-based versus fee-for-service, because so much of that is a mentality, is a philosophy of care. And what we've generally seen is that those organizations that have a predilection toward value-based care models, and I would say that the tipping point is about 30% of their contracts being in a value-based mechanism, that they are more comfortable. They've already had a head start using virtual services because of their value-based environment, but then are comfortable using the new codes and the fee-for-service modalities to get reimbursed as well. So they're benefiting on both fronts, where I think that what we've seen in the market that are more traditional service-orientated providers are slower to adopt and slower to come around to offering virtual health. So as Ann said, it's certainly an opportunity, even in a fee-for-service world, to drive virtual health services in a virtual care environment. We just see that our that our clients that are more value-based are more comfortable and have already started down this road, and then are more easily able to adopt the fee-for-service methods as well.
Great, thanks, Bill. Thanks, Ann. Appreciate that insight. Irvi, Sean, anything in particular that you're seeing with respect to either tele-ICU or hospital and home that should be added to this question and conversation?
Yes, Ken, thanks. I wanted to add a couple of points related to telecritical care. We are seeing that credentialing and privileging has been accelerated because of the emergency, and in fact, emergency use authorizations for some of the technologies that may need FDA 510K clearances, for example, have been facilitated, and that insurers and others are following this, and we're continuing to see much more rapid uptake of acceptance of these various things, whether it's the credentialing privileging process, whether it's technological integration, and that's leading to more and more acceptance of the fact that we're seeing pricing pressure, we're seeing other acceptance of the reimbursement challenges being addressed. The government's also having a bunch of task force that relate to this, and there's also some coordinated effort for compiling the data that we're getting from the virtual tele-ICU care being delivered that the Society for Critical Care Medicine, the Johns Hopkins Data Commons, and others are all working through right now. So a lot more to come, I think, is one of the key messages I wanted to deliver on that.
Great, Sean. So it's clear the genie's out of the bottle at this point, but there's still a lot more to be developed. It's a great point. Let's shift gears a little bit, and Irvi, I'm gonna come to you for this question that we're getting. You talked about the capabilities that are necessary in the ecosystem relationships that are critical to being able to pull together virtual health in general, but in hospital and home in particular. So the question that's coming here from the audience is, how are hospitals facing this? Are they outsourcing these capabilities in order to have everything that they need? Are they developing them internally themselves? How do you see that playing out, and how does that relate to the notion of extension around remote patient monitoring?
Mm-hmm. Thanks, Ken. Yeah, that's a great question. I think there's a couple different things that we've been seeing, and we've talked to a variety of clients about this. So we're seeing health plans as well as healthcare providers implementing hospital at home capabilities. So part of it, just to give the traditional consulting answer, is it depends on what capabilities that you're bringing to the table. So I think that from a public health emergency response perspective, we did see a pretty significant uptake in outsourcing because we needed to, respond to the pandemic, the, increased risk of exposure during inpatient stays that you were talking about earlier, Ken, quickly. And, we didn't have a lot of time to think through, how do you make this extremely, incredibly sustainable and scalable, but rather, how do we do what's right for patients and clinicians alike as quickly as possible? So at the beginning of the public health emergency, we were seeing a lot more outsourcing and, quick implementation of these capabilities as clients are thinking about the long-term viability of hospital and home and the broader kind of virtual health capabilities, I would say in general, recognizing, as Sean put it, the genie is out of the bottle, and frankly, seeing a lot of the benefit of being able to extend, the population that's being served, that's being observed, and really improve outcomes. Hospitals are thinking about how to in-source those areas that make the most sense. So, for example, a command center. So the clinical capabilities, especially as you have your own clinical experts in-house, that's an area that, we're seeing people really wanting to keep in-house from a provider standpoint, whereas thinking about supply chain might be something that is a very logical piece that's potentially outsourced. So if you don't have the capabilities to do quick environmental assessments in individuals' homes, for example, that might make sense, be more logical to be outsourced. So I think that as we move towards this more sustainable model and beyond this public health emergency, we will see more, I'll say, insourcing of key capabilities, but maybe not all.
All right, thanks, Irvi. Really appreciate that. And yep, Ann, I'm going to get to you in just 1 second. Let me just bump over to Sean. Just bump over to Sean for a moment, because Sean, I know we're seeing, some of this outsourced ecosystem activity playing out in the critical care environment. Maybe you want to offer a couple of thoughts in addition there.
I think it's a very appropriate question. I think a lot of organizations are well-resourced and have lots of thinking going on right now about these kinds of programs. But certainly we have seen organizations reach out to us, to others, to be able to help them think about the strategy that incorporates a lot of the questions that our good listeners are bringing up today. So I just wanted to make the point that there is real value in a focused attention towards all aspects of reimbursement as well as the requirements. And maybe, Ann, I can turn over for some of those requirements, because there are some specific things related to what we need to have organizations do in order to make sure they're checking the box on various things.
Sure, Ken, I didn't want to jump the gun there. Yes, 2 comments. I'll just make 2 quick comments. I'll pick up, answer your question, Sean, and I want to respond to something that Irvi said too, which is, the hospitals, while they apply for particularly something like Hospital Without Walls, they apply for those applications, but they are partnering with health plans. I do a lot of work on the health plan side, and we are seeing some partnerships between plans and providers to say, okay, what services are you going to provide? What services will I provide as a health plan? I am noticing an uptick, and it is allowed. I want to make it clear that you can also do this under the Medicare Advantage program. So it's not just fee-for-service. You can do it through MA with your plans and providers. And so I'm definitely seeing some interest in that. And so I just wanted to make that point. And then the other thing, Sean, to your question, yes, there is an application process. That application process is still open and ongoing for those listening today. And there are requirements, things like how are you going to do the remote patient monitoring? You have to show in your application how you'll check vitals, what technology you're using, right? You have to check that patient 2 times a day. All of that is built into the application process. So you're 100% right, Sean. CMS has built in what I call safeguards to make sure that you're appropriately monitoring and treating those patients at home. So, okay, Ken, back to you.
No, great, Ann, and that's what I was going to come to you for. So just playing with sequencing a little bit here with the questions. So thanks for being flexible with me. We've got just a few minutes remaining. I am going to float one additional question by the group, and let's see who wants to take it first, because it's one we get asked often, right, from many people, and that is, what can organizations do to build patient trust in virtual health? So, team, anybody want to start? I know we've talked about this a lot, and we've got some research in the firm that helps back up some of our perspectives. But who'd like to get us going?
I can start.
I'll be happy. Go ahead, Irby, please.
Okay, well, I'll keep it brief, Sean, and I'll hand it over to you. Maybe I'll take the consumer perspective really quick. So on the trust piece, I think part of it is ensuring that an individual, patient or consumer really understands what to expect. So managing expectations around, how is, for example, the hospital and home program going to work? How am I going to be, as a patient, how am I confident that somebody is really going to be looking over and looking after me to the same level that I would be if I were in ICU, with the physical care team, or in a hospital, or, in a doctor's office managing my chronic condition. So really taking that kind of lens of what is this making, how does this make the patient or the consumer feel? And how can we ensure that the consumer feels supported and their questions are answered as they're onboarding into the program, and their expectations are managed is one of the ways that I would recommend, and what we see in terms of building trust in the process.
I think that's great guidance, Irby. We've also been seeing in the tele-ICU world that we need to make sure people are trusting in the process for which providers are interacting with them. So ensuring that the credentialing and verification process is robust and not giving any reason to doubt what kind of care you're being given is critical. Providing ways to communicate in the context of already being aware about information that the patient may have already given via their devices is also important. Including standardized clinical content and evidence-based guidelines at the point of care for clinicians to be able to start getting comfortable interacting with other clinicians that may be virtual and that they've not interacted with in person is also a very important change management dynamic. And then there's a trust that's needed in the systems. We call it cyber posture, to harden systems so that they can be trusted not to be susceptible to attacks or for data about me, my family, me as a provider flowing out to others or out there in the open. And that's something that we're seeing as a high area of concern, obviously by the government as the National Emergency Telecritical Care Network is unfolding, but also many organizations, because we all have seen the stories and we all know the vulnerabilities that our healthcare systems have. So organizations that are FedRAMP or 3PAO certified, all of these things are things that engender trust, I believe. Ken, additional ones? Turn it over to you for those.
Great. Thank you, Sean. I think we're going to have to stop it there, and I know we're seeing some more questions that have come in. I cannot believe it, guys, that we are at the top of the hour already. This time has gone by so quickly. I do want to just take 10 seconds and really share my appreciation to all of you for taking the time today to spend with us during this webinar. Thank you to all the participants who have joined us. And Andrea, I'm going to turn it back over to you.
Thank you, Ken. Yes, thank you all of you for attending this Fierce Pharma webinar and for submitting so many great questions. And I'd also like to thank our speakers for participating and Deloitte for presenting today's webinar. This webinar has been recorded. You will be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.